Hello and welcome to Learning Anatomy with Qwuiga. Today we'll be discussing anatomy of the breast. Now, first and foremost, we have to understand the structure of the breast. The breast and its position. Positionally, the breast overlies the second to sixth rib. While 2/3 of it rests on the pectoralis major. It is a part of the pectoralis major. 1/3 rests on the serratus anterior, which is also a part of the pectoralis major. Its lower medial edge, that's the lower part of the breast towards the sternum, just overlaps the upper part of the rectus sheath. It's rudimentary in males, that is, it's insignificant, but it rudimentarily does not prevent it from being prone to the major diseases that affect the female organ. It starts developing in puberty in females, with most of the development occurring during the later months of pregnancy and during lactation. This is because this is the point when the breast, or this is when the point when the breast becomes functionally active. The breast is made up of 15 to 20 lobules of glandular tissue, which are embedded in fat, with the fat accounting for its smooth contour and most of its bulk. The lobules of the breast are separated by a fibrous septa, also known as the ligaments of Cooper, which run from subcutaneous tissues, that is the skin, to the fascia of the chest wall or the fascia of the pectoralis major, as there's a fascia that separates the breast from the pectoralis major. So we have fibrous septa, also known as the ligaments of Cooper, that run from that fascia to the subcutaneous tissues. Each lobule drains by its lactiferous duct into the nipple. That is the 15 to 20 lobules drain by lactiferous duct into the nipple, and the nipple is surrounded by pigmented areola. This area is lubricated by areolar glands of Montgomery, and these areolar glands of Montgomery are large modified sebaceous glands that may form sebaceous cysts, which in turn may become infected. Also, we also have to note that the sweat is just a modified sebaceous gland. It's a modified secretory gland, and therefore it's a modified sweat gland. Sorry, not a modified sebaceous gland. It's a modified sweat gland. That is why you can't find sweat pores around a developed breast. The breast develops as an invagination of the chest wall ectoderm, which forms a series of branching ducts. Shortly before birth, this side of invagination everts to form the nipple. That is during the 7 to 8 months. That is when the nipple is formed, and at puberty, alveolar sprout out from the ducts and considerable fatty inflation of the breast tissue takes place. This is where we see the breast becomes enlarged. With pregnancy, there is tremendous development of the alveola, which in lactation secrete the fatty droplets of milk. At menopause, this gland tissue or this alveola and ducts and lobules atrophy, that is, they die off. The nipple in men lies opposite the fourth intercostal space, but in women, due to breast size varying from one woman to another, it can lie in the 51, it can lie in as low as the 7th in another. It also carries 15 to 20 narrow pores of the lactiferous duct, scattered sebaceous glands open on its surface, and numerous melanocytes that give it and the areola a darker color. Why does it have so many sebaceous glands? The babies will suckle at the mother's breast to prevent friction between the baby's mouth and the mother's nipple. There has to be a sort of secretions around there to prevent friction and flaking of skin there. The nipple has smooth muscle cells that are disposed in a predominantly circular direction, radiating out from its base into the surrounding breast. Upon contraction induced by either cold, tactile stimuli, or emotional stimuli, the nipples become erect and wrinkling surrounding the areola occurs. And why does this occur? Because this is, you remember, they say it's a smooth muscle, and smooth muscle are mainly innervated by parasympathetic innervation. So protective innervation will cause contraction around the areola. This leads to the wrinkling and erection of the nipple. Wrinkle of the areola and erection of the nipple. The areola is a dark pink brownish circular discoid area in Caucasians and many Hispanic, but in Negroids, that is black, it is a black circular discoid area of skin encircling the base of the nipple. Color of the areola varies due to parity, that's how much children have been birthed, race, amongst other factors. At the perimeter of the areola, which has a diameter of 22 to 16 millimeters, are large pseudophoric and sebaceous glands. The breast contains glandular tissue, that is the lobes and lobus, stroma, which has the ligaments of Cooper, and adipose tissue, which is the fatty deposits in the breast. The breast is innervated by the 4 to 6 intercostal nerves, and this nerve conveys sensory fibers to the breast skin and also sympathetic fibers to the blood vessels in the breast and smooth muscle in the overlying skin and nipple. Now we have spoken extensively about the breast. Let's look at an image of how the breast looks like. So we said the breast lies on the pectoralis major. This small muscle here, this muscle, this is the pectoralis major. The pectoralis major muscle upon which the breast, this structure, lies upon. Then we can see this reddish area sort of. That is the glandular area, the glandular tissue. With time, then we can notice a thin lines extending, running along this glandular area. You'll notice thin lines running along this glandular area. That is the stroma, those are the stroma. Then also, very clearly you can see the lobus converging into the nipple. Then we have deposits of fat around the breast. This can also be seen here. This is the pectoralis major. This is the serratus anterior muscles. These are the lobes and lobus with lactiferous ducts running from there, fatty tissue in between them, the suspensory ligaments of Cooper holding onto the breast, as we have spoken about previously. Then we come to vasculature and lymphatics of the breast. Strictly speaking, the breasts are not anatomically part of the upper limb. They are not even considered part of the pectoral girdle, but as the pectoral girdle is considered to be, the transition point from the exoskeleton into the appendicular skeleton, which is the upper limb and the upper limb in this case. Breasts, however, are situated in the pectoral region, and their blood supply and lymphatic drainage are related to the armpit or axilla. The breast is supplied by branches of the axillary artery, principally its lateral thoracic arteries and acromiothoracic branches. Also, from the internal thoracic branch, there are perforating branches that pierce the first to fourth intercostal spaces and transverse the pectoralis major to reach the breast along its medial edge. The first and second perforators are the largest of these branches are from the intercostal arches via their lateral perforating branches, but are a relatively unimportant source, as most of the blood supply comes from the axillary artery or branches of the axillary artery. Venous drainage corresponds with the arteries they come with, that is the breast has its blood drained back into the axillary vein and also into the internal thoracic vein. The breast has lymphatic drainages which are also important in the sense that there is frequent development of cancer in the gland and the subsequent dissemination of malignant cell or neoplastic cells along the lymph vessels to the lymph nodes. The lymphatic drainage of the breast, as with any other organ, follows the pathway of its blood supply and therefore travels with 75% of the total lymphatic drainage of the breast moving with the tributaries of the axillary vessels to the axillary lymph nodes, and the remaining along the tributaries of the internal thoracic vessels, piercing the pectoralis major to transverse each intercostal space to lymph nodes along the internal thoracic chain. This is where we have the parasternal nodes. They also receive lymphatics penetrating along the lateral perforating branches of the intercostal vessels. Although the lymph vessels lying between the lobes of the breast freely communicate, there is tendency for the lateral part of the breast to drain towards the axilla and the major part of the internal thoracic chain, and the major part of the breast towards the internal thoracic chain. That is, though the lobes within the breast are in constant communication, doesn't mean that they have the same lymphatic drainage system. Now, the axillary nodes are about 20 to 30 in number. They drain not only the lymphatics of the breast but also that of the pectoral region, the upper abdominal wall, and the upper limb, and are arranged into 5 groups. These are the central group, the apical group, the subscapular group, the humeral group, and the pectoral group, as we see in this diagram here. Now, this here is the apical group. This is because, like the description says, all axillary nodes drain to the apical group, that is from the central to the subscapular to the humeral, the pectoral. After they have received lymphatics, they drain into the apical group of the axillary nodes, and they are located immediately behind the clavicle at the apex of the axilla, just above the pectoralis minor along the medial side of the axillary vein. That is this lighted. You can also see here the diagram here. Then also we have the central group, which is located in axillary fat. Then the subscapular group along the subscapular vessels, which is this area. Then we have the humeral group. We have the subscapular or posterior group. This is along the back, the back of the rib cage towards the subscapularis. Then also we have the humeral or lateral group, which is along the axillary vein, and the pectoral or anterior group that lies deep to the pectoralis major. So this is already showing the pectoralis major, but beneath this structure we have the pectoral group of axillary nodes. The mnemonic for remembering this can be referred to cash pec. When you have cash, you always get pecs. Then also we look at the parasternal internal thoracic nodes. These lie along the internal thoracic vessels and drain to the mediastinal nodes and tends to the thoracic duct on the left and to the right of the thoracic duct on the right. That is within the thoracic cavity. Inferiorly, they communicate distantly with the groin node via lymphatics, which accompany the superior and inferior epigastric vessels. Lymphatic spread of the neoplastic growth of the breast may occur further afield when these normal pathways have become interrupted by malignant deposits, surgery, or radiotherapy. Now, this explains how easily it is for neoplastic or neoplastic growth of the breast can give up malignant growth that goes to other parts of the body, further afield, and interrupt the lymphatic spread there, or the lymphatic movement there, and cause a lymphatic spread of the neoplastic growth there, causing cancer in different areas of the body other than the breast. Then now we come down to the mammary ridge or the milk line. This is an imaginary line that extends from the axillary to the inguinal region. In human, the ridge disappears except for a small part in the pectoral region, but in animals it rarely disappears. That is why you see them with several mammary glands that are formed along this ridge. An extension of the mammary ridge in humans leads to the formation of accessory breasts or accessory nipples. That is, maybe a man or a woman. No, let's say, please pardon my drawing. Let's say, for instance, this is the axilla. These are the axilla. No, this is the original nipples. Now the milk line extends like this onto the groin. Now if this milk line doesn't disappear, accessory breasts could form. That's why you can see someone could have, breast located, another breast located here, another breast located here, another breast located here, anywhere along this line. That is due to the line not completely disappearing. But normally this region, this is where the breast is meant to be located in. Then also we have carcinoma of the breast or breast cancer. It's a very common surgical condition, with 80% of carcinomas in the breast occurring in the upper lateral quadrant. Let's take this as the rib cage. This, for instance, is the rib cage. So this is the left breast, this is the right breast. So if this is the left breast, this is the right breast, the axilla, this will be the left axilla and this will be the right axilla. Now the lateral side of the breast is directed towards the axilla point. I say 60% of all breast cancers occur in the upper lateral quadrant of the breast. Now we know 75% of the lymph of the breast drains into the axillary lymph node, which is located upright above towards laterally. And in the case of carcinoma on one breast, the other breast and the opposite axillary nodes could be affected due to anastomosing of lymphatics between both breasts. There's linkages between the lymphatics of both breasts, the axillary lymph nodes of the right hand side and the axillary lymph nodes of the left hand side. And this could lead, this is why there's something called crossing. Breast cancer could cross from one breast even onto another one. Then in patients with localized breast cancer, a simple mastectomy followed by radiotherapy to the axillary lymph nodes is treatment of choice. The radiotherapy to the axillary lymph nodes across both ends in case neoplastic growth or malignant tissue have already affected those areas to kill those outgrowths in those areas already. Alright, today this brings us to the end of our class today. Hopefully by next week we'll be considering the thoracic cage. Please, any questions can be asked beneath the video. Thank you. Do have a great day.